Thank you for joining us today for our webinar on treating anaphylaxis. I am Jennifer Gertz, Executive Director of Food Allergy Canada. May is Food Allergy Awareness Month, and this year we are running our Know It, Treat It campaign in an effort to raise confidence in treating anaphylaxis. We want to demystify anaphylaxis and empower all Canadians to know what the signs and symptoms are and how to treat it. Today, we have two leading experts on food allergy and anaphylaxis, Dr. Moshe Ben-Shoshan and Dr. Jennifer Protudjer. Before we get started, a couple of housekeeping items. Note that this session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your own health or the health of your child. All participants are muted so we can keep the audio clear for the webinar. We'd like to thank everyone who submitted questions on registration. There are some common questions that we'll tackle in today's session. If you have additional questions during the session, please submit them in the chat box throughout the webinar, and we'll try to get to as many of them as possible. And lastly, this webinar will be recorded and shared on foodallergycanada.ca afterwards. Now, a bit of background on today's session and its format. As a parent of children with food allergy, I can attest to the fear of anaphylaxis, especially when it all began with the experience of a severe reaction in the first place. This fear is real and anxiety producing, especially when we understand that anaphylaxis can be life-threatening. And then there's this complexity of evaluating a reaction and asking ourselves, is this anaphylaxis or just a mild reaction? Should I be going to the emergency department and potentially facing long waiting times, or should I use Epi now and wait and see? To help us sort through these questions, we have two experts that have been involved in researching food-triggered anaphylaxis in Canada. Together, they will help build our understanding of anaphylaxis, that's the know it, and empower us to treat it. We will also give you an opportunity to provide your researchers with your perspectives on what makes it challenging for you to manage anaphylaxis through some polling throughout. So the format today, it's a combination of presentation, some polling, followed by a Q&A at the end. We're going to start with setting the foundation by defining anaphylaxis, the science behind it, and the research that gives us a picture of the Canadian landscape, the nature and occurrence of anaphylaxis as it is in Canada. Then there's going to be a section on covering how anaphylaxis is treated, including signs and symptoms, the role of Epi, and the recommended 5 emergency steps. And then we're going to get into a discussion on anaphylaxis emergency protocols and the current thinking on the possible evolution of those. And then we'll finish with a question and answer period. I'd now like to introduce our two experts. I'm delighted that they have made themselves available to join us today. We have Dr. Moshe Ben-Shoshan, who is a physician at the Division of Allergy and Immunology at Montreal Children's Hospital. He's established the largest cross-Canada registry that collects data on the diagnosis and management of food allergy, anaphylaxis, drug allergy, and primary immunodeficiencies. And his research has resulted in more than 100 published manuscripts. Dr. Ben-Shoshan is on the board of directors of the Canadian Society of Allergy and Clinical Immunology and also on Food Allergy Canada's Healthcare Advisory Board. We're also delighted to have Dr. Jennifer Protudjer, who is an endowed research chair in allergy, asthma, and the environment, and an assistant professor in the Department of Pediatrics and Child Health at the University of Manitoba, an epidemiologist with the Clinical Trials Platform at the George and Fay Yee Center for Healthcare Innovation, and a research scientist at the Children's Hospital Research Institute of Manitoba. All right. So we like to start with some polling questions because we want to know who's joined us today. So I'm going to ask the first poll question to be put up. So have you or your child experienced anaphylaxis caused by a food? Let's get a sense. It's yes, no, unsure. Okay, in terms of yes, we've got over half the audience who have experienced anaphylaxis triggered by a food and 38 in the no. All right, next question. Have you used an epinephrine auto-injector? Yes or no? All right, we've got 33 that have used an auto-injector and 67 not. Okay, now, regardless as to whether you have used an epinephrine auto-injector, we'd like to get a sense of your comfort on using an auto-injector? Are you very comfortable, comfortable, somewhat comfortable, or not comfortable? So we've got 20% that are very comfortable, 14% not comfortable, 34 comfortable, and then somewhat comfortable, 32. Okay, that's excellent. So we have a good understanding. We've got a number of people in the audience that have experienced anaphylaxis. We've got about a third of the audience who've used an epinephrine auto-injector, and we have a different range of comfort on using an auto-injector. So at this point, I'd like to turn it over to Dr. Protudjer, who's going to help us set the foundation, define anaphylaxis, and give us a picture of the Canadian landscape. Dr. Protudjer, over to you.
Thanks very much, and thank you, Jennifer, for the introduction, and to Food Allergy Canada for inviting my colleague, Dr. Ben-Shoshan, and I here today. Thank you very much. And again, thank you to Food Allergy Canada for inviting Dr. Ben-Shoshan and I here today to present. It's truly a pleasure to be here as we mark Food Allergy Awareness Month. And I'd like to also thank you, all of those who have attended today's webinar. So today's webinar addresses food allergy and the evolving conversation on anaphylaxis treatment. So broadly speaking, there are two types of adverse reactions to food that involve abnormal reactions after eating a food. One of those types is non-immune mediated reactions, and those are shown here in the green box. These can involve enzymatic deficiency, such as lactase deficiency, which results in lactose intolerance, as well as reactions to toxins, amongst others. But we won't be discussing those here today. The other type of immune-mediated reactions, shown here in yellow, can be further divided into two subgroups. These are non-IgE-mediated reactions, examples of which include food protein-induced enterocolitis syndrome, allergic proctocolitis, as well as other conditions rather. But again, we won't be discussing these today. Where we will focus on is IgE, or immunoglobulin E mediated reactions. These are reactions that involve the release of inflammatory mediators from mast cells after allergens interact with IgE on the surface of the mast cell. These IgE-mediated type of reactions involve the immune system, and they are the focus of today's webinar as they relate to anaphylaxis. I'd like now to take a little bit more of a detailed look at the immunology of a food allergic reaction. IgE molecules are bound to mast cells. When an allergen presents to an IgE molecule, that mast cell degranulates, or releases, if you will, various types of inflammatory mediators, including histamine and tryptase. These mediators act on different cells in the blood vessels, in the smooth muscle, and in the epithelium. And this is what causes symptoms, or creates a series of reactions that cause symptoms in the skin, lungs, and the gut. But it's important to note that not all food allergic reactions will progress to anaphylaxis. We do want to consider anaphylaxis if at least one of the following criteria are met. One, that there's a very sudden onset of symptoms, typically within minutes, but up to about 2 hours. Or there are symptoms involving two or more systems, namely in the skin, the respiratory system, whether it be the upper or the lower airways, in the GI system or the gut, as well as the cardiovascular system or the heart. Also, there is a possibility that there may be one severe symptom upon known ingestion, and that severe symptom could be a drop in blood pressure or difficulty breathing. There are 3 different grades of anaphylaxis severity. These grades are mild, moderate, and severe. Before I describe each of these different grades of severity, it's critical to note that regardless of severity, all anaphylaxis should be treated with epinephrine. Let's now take a look at each of those different grades. We'll begin with mild anaphylaxis. Mild anaphylaxis involves the skin and or mild oral symptoms. This might include mouth itching or tingling, mild lip swelling, nausea or vomiting. or it may include mild respiratory symptoms such as nasal congestion, a drippy nose, sneezing, or mild wheezing. Moderate anaphylaxis involves the gastrointestinal or the GI system, or the gut, if you will. This could include things like stomach cramps, diarrhea, recurrent vomiting, or as well as it may include respiratory symptoms such as a hoarse voice, a barky cough, difficulty swallowing, or moderate wheeze, for example. And finally, we have severe anaphylaxis. Severe anaphylaxis involves a loss of bowel control. It could involve decreased oxygen to the extremities, which is characterized by a bluish tinge or a bluish hue to the skin, or a loss of breathing. But again, I want to reiterate that regardless of severity, the person with anaphylaxis or who is suspected to have anaphylaxis should receive epinephrine as soon as possible. Epinephrine is considered the first-line treatment for anaphylaxis because this drug stops the degranulation of mast cells. Again, that is the release of mediators from mast cells, and thus limits the progression of symptoms in the skin, lungs, and gut. Most commonly, epinephrine is delivered intramuscularly via an autoinjector. Of note, there are currently 3 autoinjectors available in Canada. Here again, I want to reinforce that the importance of using epinephrine as soon as anaphylaxis is suspected cannot be overstated. People with the same types of food allergy may not react in the same way to the same exposure. There may be many reasons for this, including what we call thresholds of reactivity. That is, one person may react to a smaller amount of an allergen than another person, even if they have the same diagnosis. As such, it's critical to consider personalized guidance with your allergist and include a discussion on desired improvements in food allergy-related quality of life. In addition, those with lower thresholds may have a lower odds of acquiring tolerance, with data from various studies supporting this as it relates to different types of food allergy. Importantly, however, it is difficult to establish threshold levels through a clinical history alone. Some experts would recommend that for carefully selected patients, thresholds are determined through an oral food challenge. In recent years, much attention has been given to OIT, or oral immunotherapy. In brief, this involves having the patient consume very small doses of a food under medical guidance in an attempt to increase the threshold at which the patient will react. But any previous reaction does not predict the severity of a subsequent reaction. Reaction severity can be influenced by cofactors. Cofactors are defined as factors that may contribute to reaction severity independent of the allergen exposure. That is, a cofactor may also change how the body reacts to an allergen. And there are many different types of cofactors. And let's take a look at some of them. Some cofactors relate to the allergen itself. This could include things like the food matrix, the amount of the allergen, or the route of exposure. Other cofactors relate to the person. This might include risk-taking behaviors. It may also include things like medication, exercise, or sleep. Other cofactors yet relate to infection or other chronic conditions, including asthma and cardiovascular disease, but they can also include age, sex, and gender. Still, other cofactors relate to a person's immunology and to their hormones. It's been suggested that cofactors may influence reaction severity in one of 2 ways. One, by reducing the threshold, which we talked about in a previous slide, or by increasing the reaction severity so that those affected have a more severe response when a cofactor is present. To this point in the webinar, we've focused on anaphylaxis, including severity, thresholds, and cofactors. I now want to shift the discussion to the prevalence and the burden of anaphylaxis. Data from the United States support that the prevalence of anaphylaxis is about 1.6%. But in fact, it's likely higher than that because not all cases are reported. The greatest fear of anyone living with food allergy or who cares for someone with food allergy is the risk of death. While this fear should never be dismissed, it's important to note that death from anaphylaxis is rare. And I'll use data from the United States to provide one example. The United States, which has a population of 332 million, has a food allergy prevalence of about 7%. That's about the same as we see here in Canada. If we think about 7% of 332 million people, that corresponds to about 23 million people. In the US, where there are about 23 million people approximately who live with food allergy, there are on average about 64 to 99 deaths from anaphylaxis per year. Let's now turn our attention to Canada. I'd like to speak about the Cross Canada Anaphylaxis Registry, or CCARE. CCARE is a database of anaphylaxis cases in Canada, and it has provided substantial information about anaphylaxis rates, triggers, and management in our country. In CCARE, cases are identified by paramedics, emergency physicians, and allergists. Now, to be sure, we're only capturing those cases who present to hospital. Nonetheless, pan-Canadian data have gleaned some really important information. And as was noted in the introduction, I also wish to note that CCARE was founded by Dr. Ben-Shoshan, with whom I have the privilege of co-presenting today. Earlier, I introduced the concept of grading anaphylaxis severity. Severe reactions are a concern to those managing food allergy. Data from CCARE would suggest, however, that the majority, over 70%, are moderate reactions. And as a reminder, those moderate reactions are characterized by stomach cramps, diarrhea, recurrent vomiting, as well as a hoarse voice or barky cough, difficulty swallowing, moderate wheeze. Data from CCARE also support that hospitalizations as a result of anaphylaxis are uncommon. About 2% of those who present to the emergency department with anaphylaxis were hospitalized. And recurrent or biphasic reactions, about which Dr. Ben-Shoshan will speak further when he presents in a few moments, are similarly rarely severe. Let's now take a look at some data from Canada and specifically Montreal Children's Hospital. This is a publication from 2020. It made use of data from CCARE, but specifically in Montreal, and it provided some really interesting findings. Over the period from 2011 to 2017, the rates of food-induced anaphylaxis triggered by peanut, shown here in red, decreased by 15% overall. Anaphylaxis to unknown nuts, shown here in green, decreased by 11% overall. Importantly, these decreases were not steady over that time period from 2011 to 2017. There was some fluctuation, with even some increases noticed for specific years, but overall there was a net decrease for peanut and for unknown nuts. In contrast, over the same time period, anaphylaxis to tree nuts, shown here in blue, increased by about 7%, as did reactions to unknown triggers, shown here in purple. It's not shown here in this figure, but within the same publication, the authors also reported that there were no significant changes in the rates of anaphylaxis to other foods. The take-home message here is that anaphylaxis to peanuts and to unknown nuts appears to be decreasing, perhaps as a result of improved awareness and management within the community. The previous slide included important information about reaction rates in recent years. It's important to note, though, that during the course of any given year, data from CCARE provide evidence that rates of anaphylaxis increase during certain holidays. And indeed, anaphylaxis triggered by peanuts, tree nuts, and unknown nuts is highest in the days following Halloween and following Easter. The take-home message here is that during holidays, especially those during which children go, quote, hunting or candy, are associated with higher rates of anaphylaxis. Moreover, this risk appears to be higher amongst children aged 6 or older compared to children under the age of 6 years. The need to treat with epinephrine as soon as anaphylaxis is suspected cannot be repeated too often. And yet, CCARE authors performed a review of and a meta-analysis of the existing scientific literature on this topic and reported that across the world, the administration of epinephrine in pre-hospital settings, that is, any time before arriving to the emergency department, epinephrine in pre-hospital settings remains suboptimal. So globally, amongst children, pre-hospital epinephrine use in this study was found to be collectively about 21%. While poor, this number is nonetheless 3 times greater than it was for adults. Globally, pre-hospital epinephrine use for adults was about 7%. The data from Canada are slightly more encouraging, and they're highlighted here in yellow. Amongst children in Canada, pre-hospital epinephrine use was about 32%, whereas for adults, this number was about 20%. With consideration to biphasic reactions, epinephrine use was even lower at about 4%. And again, Dr. Ben-Shoshan will speak about biphasic anaphylaxis shortly. Wisely, though, in this review and meta-analysis, the authors also considered barriers to epinephrine use, why people weren't using epinephrine. In brief, these barriers included low prescription rates, as well as a lack of stock epinephrine or unprescribed epinephrine, if you will, in schools. In the previous slide, I mentioned that one barrier to epinephrine was a lack of stock epinephrine in schools. Before I pass back to Jennifer Gertz to introduce the next poll, I do want to emphasize that the majority, nearly 70% of anaphylaxis occurs in the home, while about 13% of reactions occur in schools or childcare, and about 7% in restaurants. Of note, individuals with a previously known food allergy have an increased odds of reactions at school or childcare, about 6%, and a decreased odds of a reaction in the home at about 10%. Thank you very much for your attention, and I'll now pass the virtual floor back to Jennifer, who will introduce the next poll.
Great, thank you, Dr. Protudjer. Some really interesting things there around kind of the different grades around anaphylaxis. It looks like most are moderate according to your data. You know, people reacting to different amounts, that introducing that idea of individual thresholds and the importance of cofactors affecting that. So lots of good information in there. And I know I just want to let people know that we have received some questions in the chat, and we will get to those following Dr. Ben-Shoshan's presentation. So let's put up the poll for this next question, because now we're going to move on to treating anaphylaxis, but we want to understand, you know, where your concerns are around using epi, or what makes you hesitate, perhaps. So if you can choose 2 of the options that are available. So first, unsure or not confident in recognizing when to use it. Second, reaction doesn't appear serious enough to use it. Third is the need to go to a hospital if epinephrine is being used, that causes you concern. Concern about using the epinephrine auto-injector incorrectly. And then the last one is concern around the pain or discomfort or side effects with using epi. So if you can choose 2 of those that best kind of reflect some of the areas of concern you have on this. All right, so unsure about, not confident in recognizing when to use, and reaction doesn't appear serious enough. Okay, so we're going to make sure we get to those in this next section and in the question period. And also the piece around the need to go to hospital seems like it was also a high choice item. So let's now turn it over to Dr. Ben-Shoshan to cover the treatment of anaphylaxis.
Thank you. So thank you for having us, and it will be a pleasure to present the next section. Okay, so I'm a clinician scientist, so my work is often inspired by clinical cases, and this is a case that I've seen in the emergency room in one of my shifts. Next. So this is a 3-year-old boy with no milk allergy. At daycare, his milk-free meal was switched with his friend's meal that contained chocolate milk, so far a very common scenario. Next. Immediately after drinking milk, he felt abdominal discomfort and developed hives. Next. He vomited once. Daycare personnel noticed the mistake and had given him diphenhydramine or Benadryl, which is a first-generation antihistamine, just like Atarax or hydroxyzine. However, he developed increased abdominal pain and dyspnea. Next. He was then administered his Alloject or OVQ about 1 hour after symptoms onset. Next. He was taken to the healthcare facility where he developed hypotension, so decreased blood pressure, and needed to be treated with 3 doses of IM epinephrine and IV methylprednisolone. Next. So this case, I think, raises an important questions. What is the role of antihistamines and steroids in the management of anaphylaxis? In this case, the first thing that the caregivers have done was giving the patient antihistamine and a first-generation antihistamine, and only 1 hour later, epinephrine. What is the logic behind these steps? Should we change the order? Probably we should. What is the data that supports that? So let's go to the next slide. So when treating anaphylaxis, we need to think about treating the symptoms of anaphylaxis. The symptoms of anaphylaxis can affect almost any organ system: breathing, circulation, so blood pressure, for example, the immune system, causing the release of other cytokines and other inflammatory symptoms, and the skin, of course, hives and swelling and itchiness. While antihistamines like first generation or second generation antihistamines, first generation, as we said, like Benadryl or diphenhydramine, and second generation like reacting cetirizine, rupatidine, Blacksten, or Arius, they help treating the hives. However, for all the other systems, the only management that actually is known to halt the progression and treat the symptoms is epinephrine. Antihistamines will not help with the breathing, the circulation, or the immune symptoms. And these are the symptoms that are more worrisome and can lead to more dangerous consequences. So epinephrine is the most effective and important treatment of anaphylaxis because it is treating all aspects of anaphylaxis, including the degranulation of mast cells. Next. The other aspect we need to think about is how fast things progress. And as my colleague, Dr. Protudjer, has mentioned, death from anaphylaxis is extremely rare, 1 per million. However, when things move, they move fast. So when you look at, this is based on a case fatalities cohort and lessons that we learned from it. And it has shown us that the average time for death when it's food as a culprit is 30 minutes. If it's venom, so being stung by a wasp or a bee, 15 minutes. And drugs, for example, getting IV antibiotics for which the patient is allergic to is 5 minutes. So we don't have a large time interval to treat it. So we need really medications that act within that time interval. So early treatment reduces potential for biphasic. As we mentioned, these are secondary reactions that occur about 1 hour to 3 days after the first symptoms resolve, and hospital admission. It reinforces the importance of in-community treatment because it takes time to get to the hospital. And because the first 30 minutes, for example, for food are actually crucial, it is really important what we do prior to arrival to the hospital. So let's look at the treatment that we have. So we have antihistamines, we have steroids, and we have epinephrine. Onset of action of antihistamines is at least 1 hour. And it will, as we said, help the hives and itchiness, but it won't help the other systems. Onset of action of steroids is at least 1 hour, and onset of action of epinephrine is a few minutes. So yes, for most cases, you don't need to treat epinephrine, but you don't want to take that chance because fatality is rare, but the only thing that will likely reduce the risk of fatality is epinephrine and not steroids or antihistamines. And as mentioned, because we need to focus on the treatment in the community prior to arrival to the hospital, we need to understand what kind of options for epinephrine auto-injections we have in the community. And luckily now we have 3 options. So we have the EpiPen that we all know, it comes in 0.15 up to 30 kilos. And once a child reaches 30 kilos, sometimes it's even considered 25 kilos or enough, according to the Canadian Society of Allergy Immunology, 0.3 milligram. So that's the auto-injector, the EpiPen. Everybody remembers the blue to the sky and the orange to the thigh. But then we have two other auto-injectors. We have the Allojet that basically gives you vocal instructions on how to use the epinephrine, more like of the size of an iPhone, if you like. It comes again in two doses, 0.15 and 0.3. And then we have more recently the Emerade, and the advantage of the Emerade that it comes also in a 0.5. Because the actual dose that needs to be given for epinephrine is 0.01 per kilo, for somebody who weighs 50 kilo, a 0.5 probably will be a better option than a 0.3 because a 0.3 will not be enough. So that's the advantage of the Emerade. So for 50 kilos and above, we often suggest to switch to Emerade because it offers the higher dose of 0.5. Mind you, in big studies, head-to-head studies, all auto-injectors were as efficient. So let's now go to the other. So we all agree that epinephrine is the most effective and most impactful treatment for anaphylaxis in the community and in the hospital. But what about antihistamines? So even for antihistamines, we can refine a bit our treatment if we think about the options we have. We have the first generation antihistamines like Benadryl, diphenhydramine, or hydroxyzine Atarax. The problem with these is that they cross the blood-brain barrier and they have substantial side effects on other systems. Because they cross into the brain, they can cause drowsiness, cognition decrease, memory loss, psychomotor effect, impairment with or without sedation in performance. They have effect on what we call the muscarinic receptors that will cause dry mouth, urinary retention, and abnormalities in cardiac rhythm. We have serotonin receptors affected by these antihistamines first generation that will cause increased appetite and weight gain. Alpha-adrenergic receptors affect dizziness, drop of blood pressure when somebody stands mainly, and then abnormalities in the cardiac rhythm. All of these are related to the first generation antihistamine mainly, and this led to recommendation by the Canadian Society of Allergy and Immunology to always use second generation antihistamines that are as effective but are much less associated with side effects. So examples for second generation that we should use now instead of Benadryl or diphenhydramine will be Reactine or cetirizine, Claritin, loratadine, Arius or desloratadine, rupatadine or Rupall, Blexten, Belastin. Next slide. So this is to reinforce that point. Why not use the first generation? First generation adversely affect the child's learning ability. There were studies on children performing exams that clearly showed disadvantages of the use of first generation antihistamines like Benadryl. First generation antihistamine induced sedation has been describing more than 50% of patients taking first generation antihistamines in therapeutic doses, so this is not even high dose. And regarding fatal traffic accidents, it was shown that use of second generation antihistamine, again like Reactine, rupatadine, Blexten, and Arius, will reduce the risk of accidents. Next slide. And this is just an example for one of a second generation antihistamine. Similar studies have been conducted on other. So here you can see placebo, so no medication at all, rupatadine, which is a second generation antihistamine, and hydroxyzine, a first generation. And you can see the effect of drowsiness that is substantial with hydroxyzine, therapeutic doses. And you can see that placebo and rupatadine a very similar effect of drowsiness. Next slide. So let's speak a little bit of biphasic reaction because this is another factor that worries us. This is defined when symptoms reappear after at least 1 hour, but up to 3 days after disappearing or resolution of the first symptoms induced by the culprit allergen with no further exposure. It occurs between 3 to 23% of cases of anaphylaxis. Why? It's not clear, but potential mechanisms have been suggested. For example, the medication effect wears off, secondary absorption of the allergen, so some of the antigens stay in our gut and being absorbed continuously over time, late phase responses, because there are some kind of inflammatory substances that are released on the first exposure when they are very high. They can cause another degranulation, another activation of the mast cell that is the main cell that participates in allergic reaction and anaphylaxis and will cause a continuation of symptoms. And as we said, most of these reactions are not severe. And I just want to mention again that the only treatment that was shown to reduce the risk of biphasic reaction will be the use of epinephrine. So why are we so afraid of use of epinephrine, besides the fact that we might be poking our child or ourselves? There are other considerations that have been raised by patients, caregivers, and the literature regarding the use of epinephrine. But if we look at the data, we see that the major side effects of epinephrine are minor. Minor effects can be seen in 50% of cases, mainly increased heart rate that resolves quickly. So children or adults will report palpitations that will resolve. In a minority of cases, less than 5%, 1.4% of patients, there'll be heart rate irregularities or neurological symptoms like confusion and headaches. Again, very minor percentage. And major cardiovascular secondary effects were associated mainly in those that had a background of heart problems and received either beta blockers or very high doses of epinephrine, much more than the doses we recommend through the auto-injector. So actually no data supporting substantial side effects with the epinephrine auto-injector except our fear of the needle here. Next slide, please. So what are the 5 stages that we currently follow when we treat anaphylaxis? Step 1, giving the epinephrine, administering the auto-injector, EpiPen, Emerade, or Alloject right away. Call 911 on step 2, or your local emergency medical services, and tell them the child or the adult is having an anaphylactic reaction. Step 3, second auto-injector that can be given as early as 5 minutes after the first dose, if the symptoms progress or do not resolve. Step 4, go to the nearest hospital right away, ideally by ambulance, even if the symptoms are mild or have stopped because of the concern regarding biphasic reaction. And then step 5, call emergency contact. So these are the main 5 steps. Let's go to the next slide. And this will be a poll question that I'm clearing the stage for you, Jennifer.
Great, thank you, Dr. Ben-Shoshan. So the next question we want to ask you about is around this decision to go to the emergency department. 33% of the respondents, when we asked about things that cause you to some concern around this, is this requirement to go to the emergency department. So we'd like you to choose one of the responses to this question. Does the requirement to go to the emergency department impact your decision to use an epinephrine auto-injector? Yes, no, or somewhat. All right, let's see what we've got here. So 54% no, 26% somewhat, and 20% said yes. So as by way of kind of transitioning this back to Dr. Ben-Shoshan, there were some situations during COVID where some groups were recommending a modification to the current 5 emergency steps, where they introduced the idea of wait and watch instead of going to emergency departments right away. So Dr. Ben-Shoshan, we'd really appreciate if you could walk us through this, the kind of what was happening there, and share your perspectives on that kind of when do I need to go into the emergency department. So back to you.
Thank you so much. We'll go to the next slide. So basically, we discussed the 5 steps that were often recommended. What happened during COVID is that patients were concerned in general regarding going to the emergency room, and especially saying that, you know, if symptoms resolve, there's no point in being in the emergency room for 4 to 6 hours just to be observed and maybe be exposed to COVID or other viruses and other infections. And actually, the American societies have come up with modified algorithm, mainly concerning step 2. Step 2, remember, is calling 911 or your local emergency medical services immediately and tell them someone is having an anaphylactic reaction. So what they suggest after step 1, which is the same, doesn't change, give epinephrine auto-injector right away when you suspect it's an anaphylaxis, monitor for response for treatment. If severe symptoms resolve, continue to monitor for recurrence of symptoms. And if symptoms do not improve or worsen, and you feel you need to get another epinephrine, so you use the second epinephrine, which is step 3, then go directly to the hospital. So that's the change that was introduced, and we are now assessing whether that change makes sense based on data and based on patients' concerns. I think this is a very important part of that webinar, and that's why it's very important for us to get your feedback regarding that. Beside that, there's no substantial change in the 5 steps, but we well, our American colleagues suspect that this might improve the compliance of use of epinephrine and might reduce the burden on the emergency room, especially at times like you know, when we have a pandemic. And it's not only COVID. So this is a referral that I wanted to bring prior to COVID that I know, and I really appreciate the honesty of the audience, because 20% said that going to the emergency room might affect their decision to use the epinephrine auto-injector. And although when you speak with families, they always say, no, with no problem, we'll go to the emergency room. I think this is a good example to show that it's not only what we think, it's really happening in actually when patients are having a reaction. So this is a 16-year-old that was referred to me, known prenatology. He does not want, so that's quote from a patient, he does not want to administer epinephrine or EpiPen to avoid calling the ambulance and getting quickly to the ER. He took Benadryl. Your opinion, please, on the plan of action or planning of desensitization to peanuts, Rupal prescribed for 1 week. So I think this demonstrates or exemplifies very clearly the fear that many of us think or feel, even if we do not express it, that by giving the epinephrine, administering that, we're sealing the fate here, and we are doomed to go to the emergency room. And hence, maybe we should not give the EpiPen or Alloject or Emerade. Wait a little bit, maybe everything will resolve, and we won't need to go to the emergency room. So we need to. It's really crucial to dislink these two activities, giving the epinephrine and going to the emergency room. And if changing the guidelines slightly and allowing patients that are fine and stable and all symptoms resolve, because usually, and that's my personal experience also, when you give the epinephrine early enough or promptly, symptoms will resolve and nothing else needs to be done. For these patients that are well monitored at home, maybe it's not crucial to go to the emergency room. So even if we change the guidelines or modify them, we still think that there are cases in which patients should go to the emergency department. When there are ongoing symptoms after 1 dose of epinephrine, clearly, we don't want the family or the caregiver to be stressed because he needs to use the second epinephrine. He doesn't have a next one if he needs. Patient who lives alone or in remote locations, so about or more, at least more than 30 minutes away from the closest emergency department. Anaphylaxis triggered by drug, insect venom, or if the trigger is unknown. And one of the reasons, because as we discussed before, the rate of progression of this reaction is much faster. And as you remember, the average time for fatality for drugs is about 5 minutes, if it's IV drugs mainly, intravenous, and for venom, 15 minutes. Delayed dose of epinephrine. So if epinephrine administration was delayed, it will not be as effective. And this is another reason to go to the emergency room. Or, of course, requirement of another dose of epinephrine. Presence of risk factors for severe anaphylaxis outcome. As Dr. Protudjer mentioned before, for example, uncontrolled asthma, cardiovascular disease, history of severe or currently uncontrolled asthma, sorry, as we mentioned, and also very severe symptoms that have been present in the past. Patient at risk of complication from epinephrine use, for example, patients who are treated for blood pressure or have a high blood pressure, ischemic heart disease, or abnormalities in cardiac rhythm. And of course, if patients or family feel more comfortable going to the emergency room, we suggest that they go to the emergency department. So Jennifer, again to you.
Yes, yes, thank you, Dr. Ben-Shoshan. So we're going to now ask you a question around this. If you were provided with the guidance to adopt a wait and see approach before going to the emergency department, would this make you more likely to use epi, or would this add more stress to managing an allergic reaction caused by food, or there's no change to my current approach? And by the way, as you're answering these poll questions, we're going to extend the session by a few more minutes so we can get to more questions. All right, what have we got for some poll responses here? So a third of you making more likely, a third of you kind of saying, gee, this actually makes it a little stressful, and the other third saying, no, it's not going to change my approach. Okay, that's really great insight, and I appreciate your feedback on that. So now I'm going to turn it back to Dr. Ben-Shoshan for some take-home messages, and then we're going to open it up to some questions.
Thank you. So in summary, there is clearly a substantial underuse of epinephrine in the pre-hospital setting, which is the most important setting to use the epinephrine in order to stop the progression of reaction. Certain cofactors such as exercise, presence of asthma, mainly uncontrolled asthma, may increase the severity of reactions. When in doubt, better to use the epinephrine autoinjector. Better be safe than sorry here. That's the approach we always preach to our patients. Do not avoid using epinephrine because of reluctancy to go to the emergency department. Prompt use of epinephrine autoinjection in the pre-hospital setting has the highest impact on anaphylaxis management, and this is related to the mode of action of epinephrine and the timing of action. Thank you, and I think we'll all be happy to answer questions now.
Perfect. If you can both turn on your webcams, we'll get started on these. All right. First off, thanks very much. We really appreciate your time on this. I think the first area that we'd like to dig into is this decision on what constitutes a mild reaction that I should treat. Because when we'll go to the very first poll, people were saying, you know, I don't think it's severe enough. That's kind of the part of the issue here, or I'm not sure I'm understanding the signs and symptoms. So let's first talk about what's the tipping point at which people can go, yeah, no, this is anaphylaxis and I should treat this with epi.
So I'll take it. I guess one of the things is that there will never be a clear-cut answer here because it's always subjective. You see your child, and often you'll need to decide, and it will not be a clear answer. We try to simplify it and say two systems, but sometimes the two systems are not very clear. And, you know, especially in a child that is nonverbal, like a 2-year-old, 3-year-old, the only thing you might see is that the child stopped playing. He looks worried, right? So that's why we added that, you know, creed, you know, better be safe than sorry. If it crosses your mind that he might need an epinephrine, just use it. The side effects, as I said, are negligible, and it's really important because the positive impact is huge. Now, again, trying to simplify it when you have two systems. So if a child presents with hives and problem breathing, of course, use the epinephrine. If he presents with problem breathing and vomiting, again, it's the respiratory and gastrointestinal system, use the epinephrine. If it's just a few hives around the mouth, you can calm down and give him just reacting or second generation antihistamine and see how it progresses. But again, if you're worried and not sure, just use the epinephrine.
Okay, now, so in the case, one person said, what about if it's full body hives? Is that in itself something where it's like, well, it's just really one system here? What's your guidance on that?
Again, so I don't want to make it a black and white thing. Full body hives, often that if a child continues to play and is comfortable, it's fine to give him the antihistamine and observe him. However, if he's uncomfortable and the full body hive seems to be progressing, and you're not sure if there's, because as I said, sometimes you're not sure if there's another system involved, like he cannot express himself and he has itchiness in his mouth and he's uncomfortable or he stopped playing, just use the epinephrine if you're not sure.
Okay, so here's another related question. So in this situation, this is an adult who lives an hour and a half away from the nearest medical care, okay? And an ambulance can take up to 3 hours. So, you know, this person is hesitating on using epi. And so the question is, should I use a second generation antihistamine and then assess whether to take epinephrine?
So I would say, first of all, you always have two epi. First, use the epi, okay? That's the first thing. If you'll need to use the second one, you think you need to use the second one, that's the time to go to the hospital, I think. As we said, I'm very inclined to support these, the modification to these new guidelines. Use the antihistamine, just not instead of the epinephrine. You can use it with, not before and not instead, okay? I mean, no harm will come from that. And also use not Benadryl, use the second generation antihistamine, as I said, because if you use the Benadryl, you become drowsy, and then you're not sure if you're drowsy because of the Benadryl, because the reaction, you know, progresses and you have less oxygen, for example.
Okay, so a related question again on this around antihistamine. So there's some folks that have environmental allergies, right? And this is the pollen season where they're regularly taking antihistamines to manage that. Can this regular use of antihistamines mask a reaction or delay the use of epinephrine because you're already using an antihistamine? I think it's kind of it's kind of trying to help disaggregate this idea of to what extent do antihistamines mask? So we might not be seeing the symptoms that we should be seeing to treat with epi.
Yeah, so as we said, antihistamines help the hives. So I want to use the word mask, I would say confuse. So you might see less hives. And if you use the first generation, you might see drowsiness, and then it might be more confusing. So use the second generation, because that will treat the hives, but it will not treat the other symptoms of anaphylaxis. So if you have another system starting, you'll see it, even with the second generation antihistamines.
Okay. Biphasic reactions, are they always severe?
Rarely severe, as we said.
Okay, rarely severe. Okay, now let's talk a little bit about, again, more on the specific of epinephrine. Is there an epi dose for under 15 kg, or what's your guidance on that?
So that's a bit annoying because there's no below 0.15, but the take-home message is that even if you give more, it's fine. You remember, we can give 2 epinephrine, in a time interval for 5 minutes, and young children do not have usually cardiac problems, so there's no problem giving a little bit more. It's 0.01 per kilo. So if a child is 10 kilos or 8 kilos, you get 0.08 or 0.1. So 0.15 is not much higher than that. So it's better to give a higher dose than not give anything.
Okay, but is there a situation where there's too much epi?
As we said, rarely. When there's a cardiac problem, arrhythmias, epinephrine is given IV and not IM, and more than 0.5 milligram. So in this situation, it could cause some harmful effects. But it's
okay, and so that the guidance on the wait 5 minutes to see it resolve, does that mean that 5 minutes is generally what it takes to start to see the impact of epi? Like when the person gives epi, what are they going to be feeling, and when are they going to start seeing symptom resolution?
Within a few minutes, they'll see improvement. It will not be complete resolution, but improvement. You can see the children, even the 3-year-old and 4-year-old, once you give them the epiline, yeah, they're not very happy with the first poke, but then within 2 minutes, they're all perky and happy and start to play and ask for a sticker. And with the adults, we actually, when the reaction progresses, please give me my epinephrine. Don't play with me, dad or mom. I need my epinephrine and give it to me. Because the improvement is almost immediate, almost. I would say a few minutes.
Okay. In this situation, we're talking about a young woman who is pregnant. Okay, what's the recommendation on the treatment of anaphylaxis? Is epinephrine safe for the unborn child?
It's more unsafe to let anaphylaxis progress at that case because the embryo will have less oxygen, right? So we need to give epinephrine if it's required, if the pregnant woman has anaphylaxis. The only change is you don't put her on her back because it might decrease blood pressure to the embryo and to herself because it will press on the inferior vena cava. So you need to put her on the left side lying down rather than, and I mean, at the end of the day, you do what's most comfortable for the patient. So you don't, force them to lie down if they're uncomfortable that way.
Okay. Now, is it true, this question is asking whether it's true when you use epi that it hurts your heart muscles, and that the more you use it, that the weaker your heart becomes?
No, it's a bit of a myth. As I said, it increases the contraction of the heart muscle, and that's what we want because anaphylaxis decreases the contraction and you don't get enough blood to your body. But one use of epinephrine in somebody that does not have a cardiac problem is safe. And the worst thing that will happen, your heart will beat faster, but that's what we want. We want more blood because otherwise you get shock and you'll die from anaphylaxis.
Right, okay. Now also the regular use of antihistamines or epinephrine, again, if you're using this regularly, does its effectiveness start to wane?
No. I mean, we have children and adults with chronic urticaria. This is hives on and off for 6 weeks. And they get up to 4 times the dose of second-generation antihistamines for years because only 10% resolve each year, and it does not lose its effectiveness. You might think so because your background disease is becoming more severe. Or we have more pollens now. So many people come to me and say, oh, it's horrible, reacting doesn't help anymore. It's because probably I use it too long. No, it's because the pollen count is much higher now. I mean, we have global warming, we have more pollens, and it's harder to control it. It's not because the antihistamines are less effective.
Okay, so this one is around what key words to use with hospital merge for triaging of potential anaphylaxis, and maybe what you should be telling the ambulance drivers as well.
Jennifer, I'll let you. I think the stage is long here.
Language is really important. So in terms of if you were somebody who was presenting with a merge or presenting with anaphylaxis, had suspected anaphylaxis, we're looking at words like anaphylaxis, calling it what you think it is, indicate to them that you have or you have not used your auto-injector, explain your symptoms in the best way possible in plain language, so that they're easily communicated, that they're not being misinterpreted, that we're not using words incorrectly. And if it's a child, if you are the caregiver of that child and the child is not able to express their symptoms, describe what is happening, what has happened and what continues to happen when the onset occurred. And if you know the food, in this case, what the child ate, then relay that information as well. So be very forthright.
I want
Excellent.
also to add, Jennifer, that I had a case of a child that was allergic to wheat. And the thing was that he went to the fridge and ate, and his sister was not allergic to it, so there was pizza. He ate a pizza, and he immediately felt, swollen lips, and he was like 6 years old, running around. You know how they are 6 years old, and had some bluish tint to his lips. But then the ambulance came, and it's like a conspiracy between families and care, and even us as caregivers. We try to avoid to give epinephrine. Say, oh, he's running well, we don't need to give him the epinephrine. If they took him in the ambulance to the hospital, he lost his consciousness in the hospital, got IV drip, go to ICU. I mean, it's really crucial not to ignore this early warning sign because the child is running around. Running around can actually make it worse because it's like an exercise adding to the severity of reaction. So we need to be careful. This child could be deathly allergic to wheat. So please take consideration. Please use the epinephrine if you suspect. Don't spare the child. It's better to poke him now and make him cry, for a second and save his life.
Okay, so I'm going to leave with this last question. Actually, we've got two questions, so if you don't mind sticking around. So the second last question, how do we make it clear to a child when to self-administer epi? That's a tough one. I mean, Dr. Ben-Shoshan, you're dealing with a lot of pediatric patients. How do you talk to them about when they should self-administer?
It depends on the maturity of the child, right? I mean, I have children that come to my office and say, I just don't want to do the chandrazool, for example, the skin test is negative because I do not want to use the epinephrine. There is that fear and unexplained fear from the use of epinephrine. I mean, it's clear that, most of us are afraid from needles. But I think it's really important to make them use one time because once they use it and they see the effect, all studies suggest that they tend to use it more in the future. The ones that are too scared of using it are the ones that are more a danger. So, even making that first fight, helping him, overcome that barrier first time, I think will change the course and empower him in the future because he'll see that he has control on his, destiny, on the way things progress, and he can stop it.
Okay, great. Okay.
Sorry, if I can add to that, I think the other piece is the anxiety around using an auto-injector. Some anxiety, moderate or mild amounts of anxiety can actually be very adaptive. They can help the person make informed choices about food allergy and anaphylaxis. And so having the opportunity to practice with an auto-injector, whether it be with a trainer or actually using a device, really does make a huge difference and can motivate the decision to use an auto-injector when it's necessary.
Great. Okay, well, listen, we've kind of gone beyond our time, but I did have that one last question. And this is to you, Dr. Ben-Shoshan, on this idea of wait and watch, right? When would you recommend to patients to adopt that kind of wait and watch before going into emergency departments?
So I'll say somebody that is comfortable using the epinephrine auto-injector and use it fast. So that's one thing. The other one, somebody that does not have risk factor like uncontrolled asthma and does not live too far from the emergency room. And as we said before, whoever feels uncomfortable and wants the help of the management team in the emergency department should not hesitate and go to the emergency department. I just don't want, things happening like in that referral. Somebody who said, I did not want to use epinephrine because I did not want to go to the ambulance and I did not want to go to the emergency room. That's the opposite of our objective.
Yes, and I think it's also that epi first, not antihistamines, right? That's where antihistamines along with epi first. Yes. Okay. Well, listen, we've gone over time, so I want to thank you both for sharing your time and expertise. In terms of what's next, you're going to get a short survey through GoToWebinar. Immediately after this session, it'll pop up on your screen and you'll receive that survey also in the mail in the next hour. Please complete it. It really is important for us to get your feedback so we can improve future webinars and we can know what questions are still out there remaining to be answered. We've also compiled our key anaphylaxis resources for you, so you can access them at foodallergycanada.ca/anaphylaxis resources. You'll find our brand new epinephrine sheet, as well as the 5 emergency steps. We ask you to join our Know It, Treat It conversation and get involved in this campaign and share your personal story for a chance to win some exclusive prizes, including a $250 Visa gift card. You can share our animated, you can also share our animated GIFs and take a photo of teal monument lightings throughout the country. And a schedule of those lightings is actually on our site as well. So go to foodallergycanada.ca/FAM, FAAM, for the details on that. Also this month, we have 2 Facebook Live sessions on treating anaphylaxis with epinephrine auto-injectors and common mistakes to avoid. So there's one in English with Dr. Julia Upton and another in French with Dr. Ben-Shoshan. And again, if you feel like there are more questions that you didn't get answered in today's session, these are another opportunity for you to get those questions answered. Find details of these events at foodallergycanada.ca/FAAM events. Lastly, stay tuned for our email next week because we're launching our Listen and Learn series with the first session on needle-free forms of epinephrine and what's in the development pipeline, as well as some new videos explaining what food allergy and what is anaphylaxis featuring Dr. Ben-Shoshan. They're excellent resources that really help explain the science and what happens to your body and really reinforce how epinephrine is the ideal treatment for anaphylaxis. So please feel free to share those videos with others to get a better understanding of the condition. Now I'd like to really thank our supporters for this, because today's webinar was supported by the Shorter Foundation, the Sean Delaney Memorial Golf Classic, Allerject, the Peanut Bureau of Canada, EpiPen, and made possible from the donations from viewers like yourself. So to help us continue this type of programming, we would be delighted if you would consider a donation today. You can visit foodallergycanada.ca/donate to learn more about the impact your donations make. Thank you for your participation in today's webinar. You can view a recording of this webinar at foodallergycanada.ca shortly, and we will please feel free to share it with others who may benefit from this content. This now concludes our webinar.